Let's start talking about the medicines that we can use in rheumatoid arthritis. Very important topic for INICET as well as NEET. So let's start, and it is also useful for your final prof exams if you are an MBBS student. So it is also helpful if you are going through Harrison, if you are reading Harrison, if you are going through a medicine postings right now. Let's start. So the treatment of rheumatoid arthritis or the medications can be divided into, one is what do you give if a patient has come with acute symptoms of rheumatoid arthritis, that is joint swelling, morning stiffness more than 1 hour and pain in the joints. So if a person comes with those things, then the medications are, one is NSAIDs, then we have steroids. So we can give the patient and we can put the patient on NSAIDs like etoricoxib, naproxen, right? And the second option is steroids. Now we can't give a patient steroids for a long time. We have to suppress the antibody levels in the patient. So what do? We have to switch the patient to some steroid sparing agents. Now these steroid sparing agents, because they also lead to remission in rheumatoid arthritis, they also modify the disease, as in they reduce the inflammation and they change the morphology of the joint. They change a diseased joint into an almost normal joint, and that's why they are also known as DMARDs, that is disease modifying anti-rheumatic drugs, right? So we have DMARDs and we will talk in detail about DMARDs, right? So disease modifying anti-rheumatic drugs. Let me write this here, disease modifying anti-rheumatic drugs. So in DMARDs, we have conventional DMARDs and then we have biologics. So we can divide DMARDs into conventional and biologics. Among conventional, we have 4. So we have HCQS, hydroxychloroquine sulfate, we have sulfasalazine, very effective, very good medication practically too. Then we have methotrexate. Then we have leflunomide. Whenever I say this word leflunomide, the word LFT comes into my mind, because this is one drug that affects the LFT. So you need to monitor LFTs of the patient, right? So L for leflunomide, L for LFT. That is how I try to remember this during my exams. So if we talk about biologics, now biologics are the medications. These are the new medications, and these are the medicines that are either inhibiting the receptors or inhibiting some molecules involved in the pathogenesis of rheumatoid arthritis, or these are monoclonal antibodies acting against the inflammatory agents that have increased in rheumatoid arthritis, right? So these can be TNF alpha inhibitors, which can be infliximab. I hope you have the notes for these lectures. Certolizumab. I have also put my notes in the link. So one is infliximab, certolizumab, etanercept, adalimumab, and golimumab. Now we know whenever the word mab and medicine ends with mab, it's a monoclonal antibody, right? Then we have IL-1. So IL-1 is one molecule, IL-6 is another molecule involved in rheumatoid arthritis. So IL-1 and receptor antagonist, which is anakinra, right? So receptor inhibitor, anakinra, okay? Then we have IL-6 monoclonal antibodies against IL-6, interleukin 6. So we have tocilizumab, and we have something new, that is sarilumab. Then we have CD markers. There are certain CD markers which increase in rheumatoid arthritis, which are involved in the pathogenesis of rheumatoid arthritis. Now these CD markers are like CD20, CD28, CD68, and we have inhibitors, we have medicines that act through these CD markers. So for example, CD20 monoclonal antibody against CD20. So that would be rituximab. Because it is a chimeric and monoclonal antibodies, it contains the alphabets XI in it. So CD20 monoclonal antibody. Then we have CD28 to CD80 inhibitors, receptor inhibitors, which is abatacept. Then we have these small molecules, JAK molecules, which are also involved in the pathogenesis of RA. And when I talk about small molecule inhibitors, I am talking about JAK1, JAK3 inhibitors and again the other small molecule inhibitors. So in the other small molecule inhibitors, we have tofacitinib, and in JAK1, JAK3 inhibitor, we have baricitinib. So see, inhibitor, tinib, small molecule inhibitor. So baricitinib, tofacitinib. So these are the biologics that are involved in treatment of rheumatoid arthritis. Now if I want to tell you the doses, let me tell you the doses, but then I have to use another marker. So let me use another marker, guys. So let's start with HCQS. We all know the dose starts with 200 milligram in a day, and we can go up to 400 milligram. So we can make it twice a day, 200 milligram twice a day, right? And the toxicity that HCQS can lead to is retinotoxicity. So retina, one is retinotoxicity, and another is cardiotoxicity. It can lead to arrhythmias. HCQS can lead to arrhythmias. And it also leads to skin pigmentation. Snake-like skin. So skin pigmentation. If we talk about sulfasalazine, the dose is 500 milligram BD up to 1 gram BD. And sulfasalazine can lead to cytopenias. It can lead to cytopenias. If we talk about methotrexate, the dose is 10 to 25 milligram in a week. Okay, and it can lead to lung, so pulmonary fibrosis, liver, hepatotoxicity, and can also lead to bone marrow suppression. So fibrosis, pulmonary fibrosis, hepatotoxicity, and bone marrow suppression, leading to again cytopenias. Then we have leflunomide. The dose ranges from 10 to 20 milligram OD once a day. And leflunomide as well as methotrexate are pregnancy category X medications. That means they have been proven to be teratogenic to human babies. So you can't give it. There is no point even discussing about this. Methotrexate and leflunomide category S. Please remember. Right. Then if we talk about the biologics. Now infliximab, I have already written the doses in my notes. So you can also find the doses in my notes, but let me tell you here, if you're noting down with me, then let us increase the space, right? So if we talk about infliximab, the dose is, it is an IV medication and the dose is 3 milligram per kg IV. And it is given in doses week 0 to 6. So 3 milligram per kg IV week 0, then second week, then week 6, and then every 8 weeks. Every 8 weeks you have to give this for induction for at least 6 months, right? And then maintenance depends on patient symptoms. So that is one thing. Then etanercept. Etanercept is a subcutaneous medicine, so 50 milligram subcutaneous weekly. Adalimumab is 40 milligram subcutaneous, and this is alternate week. So एक week छोड़ के एक week. So adalimumab. Then we have golimumab. This is 50 milligram subcutaneous once in a month, right? So please remember, etanercept, adalimumab, golimumab, all are subcutaneous. Even certolizumab is subcutaneous, and this is 40 milligram subcutaneous week 0 to 4, and then 200 milligram alternate week. Okay. So please remember, infliximab is IV. So I for infliximab, and I for intravenous. Okay. So the only IV TNF alpha inhibitor is infliximab. And the dose is this one, 3 milligram per kg IV, week 0 to 6, and then every 2 months. Once in 2 months. And then certolizumab, etanercept, adalimumab, golimumab, all are subcutaneous. And please remember the doses like this, 40, 50, 40, 50. Okay. Certolizumab is like infliximab only. So subcutaneous week 0 to 4, followed by a total of 200 milligram alternate week. Then etanercept is 50 milligram weekly. Adalimumab is 40 milligram subcutaneous alternate week. That means once in a fortnight. And then golimumab is 50 milligram subcutaneous once in a month. So once in a week, once in a fortnight, and then once in a month. 50, 40, 50. Very easy to remember. If you make up a chart in your mind, you will remember the doses. Okay. You just have to remember one thing. And that one thing is that one thing can be any one thing. You can make your own mnemonics, right? So for me, how I try to remember this is CEAG. So CEA is a tumor marker, and I used to remember this CEAG. CEAG, that is KIAG. I used to remember it like that. And once I remembered CEAG, if I had this in my mind, CEAG, I could figure out the doses because I knew the doses start with 50, 40, 50, 40. So C is 50 milligram, E is 40 milligram, A is 50 milligram, then G is 50 milligram. 40, 50, 50, right? So C is 40, then 50, then 40, then 50. And more frequent doses to less frequent doses. Okay. So C week 0 to 4, then once in a alternate week, once in a fortnight. Then etanercept, once in a week. Then adalimumab, once in a fortnight. Then golimumab, once in a month. See, the frequency reduces. So remember it, try to remember it like this. Then if we talk about if we talk about anakinra, the dose is 100 milligram subcutaneous daily, OD. Okay, so daily. If we talk about tocilizumab, that is so C से याद कर लो ना 6. So this is how you remember that tocilizumab is a monoclonal antibody acting against interleukin 6. So tocilizumab is the dose is 4 to 8 milligram per kg IV once in a month. 4 to 8 milligram per kg IV once in a month. And serilumab is a new agent. You only need to remember the name. You don't have to remember the dose. But tocilizumab, remember IL-6, C for 6. And then the dose is IV. This is again IV, right? So here infliximab was IV, here tocilizumab is IV. Everything else in between is subcutaneous. Please remember that. Rituximab we all know is IV. Okay, we all know that rituximab is IV. And the dose of rituximab is 1 gram day 0 and 1 gram day 14. And then you repeat after 6 months. Then you repeat after 6 months, right? And you can go on repeating till your CD markers are 0. So you monitor your CD20 markers, and then you decide to give rituximab for how long you need to repeat, right? Then you decide. Now coming to these medicines, the CD8 markers and the small molecules and the JAK inhibitors, right? So abatacept is again an IV medication. Abatacept is again an IV medication, and the dose is actually a weight-based dose. So less than 60 kg person, the dose is 500 milligram. 60 to 75 kg person, the dose is 60 to 100 kg person, the dose is 750 milligram. And more than 100 kg, very rarely, the dose is 1000 milligram. And we give it IV. So IV, the dose is week 0 to 4 and then monthly. Week 0 to 4 and then monthly, right? Tofacitinib is a oral medication, 5 milligram oral BD. Very important to remember this. This is the only oral biologic, right? And then baricitinib, you don't have to remember the this thing. You only have to remember that it is also an SMI, a small molecule inhibitor, and it acts on JAK1 and JAK3. Please try to remember this. So this is how you remember the disease modifying agents in rheumatoid arthritis. Take a screenshot of this. I hope you have already written down, or you have my notes as printouts. If not, you can take a screenshot and revise this just before your exam. This is something important, right? And the important things, let's repeat the important things here. So we have NSAIDs like etoricoxib, naproxen if a patient is coming with acute arthritic symptoms. We have steroids, then we have disease modifying anti-rheumatic drugs, which we divide as conventional and biologics. The conventional are the 4 medications are HCQS, sulfasalazine, methotrexate and leflunomide. L4 leflunomide, L4 LFT, methotrexate, leflunomide are pregnancy category X medications. These are all oral medications, conventional are all oral, and the only oral biologic is tofacitinib. Oral biologic is tofacitinib. And we know the doses. HCQS can lead to retinotoxicity, cardiotoxicity, skin pigmentation. And then biologics, we have TNF alpha inhibitors, we have IL-1 receptor inhibitor, we have IL-6 monoclonal antibody, we have monoclonal antibody against CD20, then we have CD28 to CD80, then we have small molecules like JAK1, JAK3 and another small molecule inhibitor, that is tofacitinib. These are the biologics. So there are mainly 3 categories, right? TNF alpha inhibitors, interleukins, IL-1, IL-6 and then the CD markers. And then the small molecules, so 4 categories, right? Small molecule inhibitor. So these are the 4 molecules, these are the 4 categories that are involved in the pathogenesis of rheumatoid arthritis too, right? And these are the doses. So here in TNF alpha inhibitors, infliximab is the only IV TNF alpha inhibitor. All are subcutaneous. Tocilizumab C26, please remember this, C for 6, it is again IV. Rituximab is also IV. Rest all are, this is abatacept is also IV, rest all are subcutaneous, and one oral is tofacitinib. So try to remember this. Now this page is utterly important for your revision. Okay, now let's discuss some PYQs of rheumatoid arthritis that have been asked earlier. Let's try to remember that. And I forgot to put on my mic, so give me 1 minute and let me just put on my mic so that the noise is obliterated. There is too much of noise going on. Here we go. Yes, very good. I hope I am audible. I've been talking since morning. Okay, but this is fun. This is the most fun part of the day. Okay, teaching you guys. I actually miss my preparation days. Very less number of troubles. We only had to focus on one thing, and that was our exam. And now in our routine day-to-day life, there are so many things. What happened to this patient? What is the MRI of that patient? Young patient with facial paralysis, not getting treated. What will happen to his face? How to treat, then read about it again and again. What can we do with refractory cases and dementia patients? Prognosticating the caregivers, waiting for a stroke patient's MRI to decide upon the treatment because it is a time-sensitive thing. Telling headache patients to take care of their lifestyle, otherwise they will not get rid of this tendency of headache. And then coming back home, then you have family to take care of. Although I have a 24-hour help and a driver to help, so but still there are so many things to think of. I think student life, I really miss my student life. So I hope you all are enjoying. Don't take too much stress of the exam, but be focused. Not taking stress doesn't mean waste your time. No. stay focused. Focus is one thing that will take you through the exam. It's not a very tough exam. Please remember this. It is not very tough. It is equally tough for everybody. You don't need 2,000, 3,000, 30, 40, 50 seats. You only need one seat in that exam. Okay, and only you can crack that exam for that one seat. Just focus on that one seat. That's it. So let's talk about PYQs. Okay. So the previously year asked questions. One is inflammatory arthritis versus non-inflammatory arthritis. Non-inflammatory arthritis. Okay. So inflammatory arthritis, we have RA. So we know we have morning stiffness. Then pain and swelling is there in both. Morning stiffness is there in inflammatory arthritis. Synovial fluid WBCs are high, more than 2000 per microliter in inflammatory arthritis, and only 200 to 2000, so less than 2000 per microliter WBCs and synovial fluid in non-inflammatory arthritis. If morning stiffness is there in non-inflammatory arthritis, it is less than 1 hour, and in this one it is more than 1 hour. So this time becomes important, right? New bone formation is uncommon. New bone formation is uncommon. Minus plus. Okay, minus plus. One more of minus. And in this one it is plus plus plus. And then in X-ray we have rarefaction. We can see something known as rarefaction. And here we can see osteosclerosis. One non-inflammatory arthritis is osteoarthritis. Right? Examples of inflammatory arthritis and examples of non-inflammatory arthritis. Non-inflammatory arthritis, NOT, that is neoplastic, osteoarthritis, post-traumatic arthritis. Inflammatory arthritis, RA, gout, reactive, SLE, other autoimmune conditions are all inflammatory. Okay. The next question that is asked is the associations with HLA. HLA association. Okay. So HLA, sorry. HLA. So DR2, DR3, DR4, DR8, B51 and B27. We'll remember it like this. So DR2, SLE, DR3, Sjogren's, DR4, rheumatoid arthritis and pemphigus vulgaris, DR8, JRA, juvenile rheumatoid arthritis or juvenile arthritis, B51, we all know Behçet, and B27, ankylosing spondylitis, Rheumatoid arthritis, psoriatic arthritis. Okay, psoriatic arthritis, Rheumatoid arthritis, ankylosing spondylitis, all are associated with HLA B27. And then one important one, DQ2, celiac associated arthropathy. Celiac is also, it is a gluten sensitivity disorder, and it is sorry, it can also present with arthritis joint like features because it is an autoimmune condition again. So that is associated with HLA DQ2. Very good. Now what is the pattern of joint involvement? Okay, so the pattern of joint involvement in osteoarthritis, in rheumatoid arthritis, and in psoriatic arthritis. What is the pattern of involvement in hands? Okay, so 4, 1, 2, 3, and 4. Okay, 1, 2, 3, and 4, right? So what are the pattern of involvement of joints? Right. So osteoarthritis. You know what is PIP and DIP, right? So PIP is proximal interphalangeal joint and DIP is distal interphalangeal joint. So if these are my phalanges, then this is the distal interphalangeal joint and this is the proximal. Proximal to wrist. Whatever is proximal comes near the wrist is proximal, okay? So these are proximal, these are distal. So osteoarthritis, PIPs are involved, DIPs are involved. The first CMC, the first carpo-metacarpal joint is involved, PIPs are involved and DIPs are involved. Okay. MCP and wrist are the joints that are spared. Now, if I talk about rheumatoid arthritis, then wrist is involved, PIP is involved and MCP is involved. So, MCP and PIP, these three in line. Please remember in line. These are all in line. Remember this, rheumatoid arthritis. Okay. DIP joints are spared. In psoriatic arthritis, DIP and PIP both involved. DIP and PIP both are involved. Because nails are involved, so please remember in psoriasis nails are involved. And what is the joint near the nails? It is the DIP. So DIPs are also involved, right? So we have this involvement of joints in osteoarthritis, rheumatoid arthritis and psoriatic arthritis. Please remember this, bachas. Okay. All right. Then there is one thing that in osteoarthritis, what are Heberden's nodes and what are Bouchard nodes, right? So how do you remember that? So see, when DIP is involved, these are known as Heberden's nodes. Heberden's nodes. When there is no joint swelling, but there is node formation. You must have seen elderly patient with slightly elevated node-like involvement of the joints of fingers, right? So those are Heberden's nodes and Bouchard nodes. And when the PIPs are involved with osteoarthritis, these nodes are known as Bouchard's nodes. Okay. So how do we remember this? So I used to remember it like BP. Only one thing. Try to remember this with BP. Just remember BP. You can remember BP, right? It is blood pressure. Right here, it is not blood pressure. So it is B is for Bouchard nodes. Bouchard nodes involve the PIP joints. Bouchard nodes involve the PIP joints. So please remember BP as a mnemonic. You can make your own mnemonic, beta. These are the ones that I use while doing my preparation for AIIMS, and these are the mnemonics you are most welcome to use. You're most welcome to make your own mnemonics, but this is how I remember it. BP, Bouchard nodes, PIP joint. Okay. So if a question comes and I want to remember in exam, I did not try to remember the page where Bouchard node, Heberden node was written, whether I wrote DIP, whether I wrote PIP. Your brain doesn't work like that during an exam. Your brain works on mnemonics, trust me. So I only try to remember BP. And I know that Bouchard node, PIP joint, that's it. Right? So if they ask about Heberden node, I know it is a DIP joint, involving the DIP joint. The next question that is usually asked is Charcot joint. Some people pronounce it as Charcot. Some people pronounce it as Charcot. Charcot joint. I used to pronounce it as Charcot joint when I was a student. That was also okay. And so pronunciation doesn't matter. Knowledge about the disease is more important. So Charcot joint, what is Charcot joint? So one question is this. So I'll ask you questions and you please write down. So write down the diseases. Please write down your answers. Okay, so write down the diseases that lead to Charcot joint. Okay, and then we'll discuss the answers. The second question is, uh, what can be the complications of rheumatoid arthritis? Two very common complications of rheumatoid arthritis. Please answer. Write your answer. What exactly is RA factor? What exactly is RA factor? Is it a molecule? Is it a small molecule? Is it a JAK molecule? Is it an interleukin? What is it? What is an RA factor? Okay, this is the basic. You should know about it. Then tell me one RA medicine, rheumatoid arthritis medicine, that can lead to nephrotic syndrome. That can lead to nephrotic syndrome. Then what will you find? What is the difference that you find in a joint X-ray in an RA patient and in an SLE patient? Okay, answer. Come on, I'll give you a minute. All right. Okay, let's discuss. So Charcot joint is actually a neuropathic joint. It is a neuropathic joint, and it is actually a progressive destructive arthritis. And why is it called a neuropathic joint? Because there is nerve involvement too. So it is a progressive destructive arthritis associated with loss of pain and temperature sensation, and also joint position sensation. So the joint position sensation, proprioception, pain and temperature, or all of these are gone, or any of these, or all of these, right? So that is why it is known as neuropathic joint. So nerve plus joint, Charcot joint, right? Now the DTRs, if you ask me how are the deep tendon reflex in Charcot joint, they are normal and the joint movements are reduced. It is not an inflammatory joint pathology, joint movements are reduced. What are the disease processes that lead to Charcot joint? So one important one is diabetes, then there is syringomyelia, then there is amyloidosis, leprosy, Tabes dorsalis. Tabes dorsalis. Okay, so diabetes, syringomyelia, amyloidosis, leprosy, and tabes dorsalis. Complications of RA: amyloidosis, a systemic complication; septic arthritis, a local complication, a localized complication. Okay. What is RA factor? RA factor is an IgM antibody against the FC portion of IgG. It is not a very sensitive marker, only positive in 75% cases of rheumatoid arthritis, but it is a good prognostic marker. So if a patient is having a positive RA factor, for example, the limit is usually up to 10 or 14 units, but if it is, for example, 16, a patient, when you start the patient on treatment and it comes down to 20, that's a good sign. That means your treatment is working. So it is a good prognostic marker. One rheumatoid arthritis medicine that can lead to nephrotic syndrome is penicillamine. So also remember, rheumatoid arthritis factor not used for screening. So if you suspect rheumatoid arthritis in 5 patients, you cannot get RA factor done to tell that yes, this one has RA. No. So it cannot be used for screening. It is not specific for RA. It is not specific for RA, but it can be used for prognosis. It can be used for monitoring. A negative RA factor does not rule out rheumatoid arthritis. And a positive one can also be found in hepatitis B, in SLE patients, and in TB patients, and in 5% of normal population. In 5% of normal population. Okay. Penicillamine. The answer to this is penicillamine, and here we find erosions. And SLE is a non-erosive arthritis. So non-erosive arthritis. So no erosions. We do not find any erosions. So that's all about rheumatoid arthritis. All the best.